Hi, everyone. My name is Yasi Ansari, and I'm a registered dietitian nutritionist and a certified specialist in sports dietetics, specializing in eating disorder work. Today is, this whole week is Eating Disorders Awareness Week. And today I'm joined by Jessica Setnick, an expert in nutrition counseling of eating disorders and the author of the new Pocket Guide to Eating Disorders, third edition. She has authored multiple resources, and she's been internationally recognized and has a signature training workshop for health professionals called Eating Disorders Bootcamp. I'm so excited to introduce Jessica, to have her come on. And just a fun fact, I met Jessica at Fancy, and it was one of the most exciting experiences because she has helped me gain the confidence I need in working with this specific population. So Jessica, when you're ready, please join us.
I'm here. I'm excited. Hi.
Hi. So I'm so excited to dive right into the Pocket Guide to Eating Disorders. And
I got it right here.
Amazing. And so 3 things I want to make sure we cover today: why this matters for every dietitian or health professional, what makes this book different than the other resources that are out there, and the part that I'm so excited about is just having a candid conversation with you and going through the Jessica pep talk when it comes to counseling this population.
That's a nice way to think about it. Well, I can tell you that it's very stressful to know that there's just people out there that might be watching, or worse, nobody watching. So I'm just thinking of it as a conversation with you too.
Yes. No, I'm really excited. And something I want, we can't see who's necessarily watching us right now. So if you can introduce yourself in the comments, please do. Tell us the population you work with, ask your questions, share your comments, take photos if you want to, share snippets from this on social media. We want to get the word out there, but really we want this to be an engaging experience where we're just having a fun conversation, and hopefully everyone will take something away with them, which I know they will.
Thanks for your confidence.
Oh, thank you. Okay, so let's get started. Sure. Something I want to start with is just going through, let's go to page 1.
Okay.
Okay. Well, page official 1. All right. So I noticed, and this is something that we're going to do. I've highlighted, as you guys can see, I have some little Post-it notes here. There's a quote that says, "How innocent we were when we thought working with eating disorders was a choice," by Shirley Tarleton, dietitian and CSSD. So who is Shirley Tarleton? And what did you mean by this quote? I have an idea, but I want you to explain.
Sure. So what I noticed, so I teach this workshop called Eating Disorders Bootcamp. And is that me? Making a noise?
No.
Okay. Okay, sorry, it's so distracting. So I teach a workshop called Eating Disorders Bootcamp. And what I noticed was, and it's now an online course. And what I noticed was, I guess all the eating disorder dietitians in America have already taken it, because all the people that were, you have to do a 30-minute phone call with me instead of a test. We do a phone call. So I talk to every person who takes my course, and they were from all over the world, all over the country. And the theme was they were not eating disorder specialists. So it was sports dietitians, GI dietitians, everything, geriatric dietitians, native reservation dietitians, rural clinic dietitians, long-term care dietitians, every kind of dietitian that is not an eating disorder specialist. There were a few eating disorder specialists in there. Oh my gosh, boarding school dietitians, like places you didn't even know had a dietitian. And I'm talking to all these people around the country, and I'm thinking, okay, there is a theme, there is a consensus growing here that every single dietitian, because of the nature of our work, because we're talking about food and eating, we're talking about eating problems, we are the ones who are going to uncover eating problems a lot of the time. And so these dietitians that I was encountering were really the face of this book for me. If an eating disorder specialist has a lot of books to choose from, Great books.
Right.
But someone who's a dietitian, but not an eating disorder specialist, kind of doesn't know where to turn. And so that's who I wrote this book for. And Sherry Tarleton, who did give me permission to use her quote here, but probably didn't know we'd be talking this extensively about her on this live. She is actually a tertiary care dietitian at a very famous clinic. You would know the name if I said the name, where her only patients are people who are so gastrointestinally compromised that they only have tube feeding or TPN as their sole source of nutrition. And so she was saying, I never thought I would be the person identifying eating disorders for my team of PhDs, MD PhDs, these like genius level people that she's working with. And yet she's the one who's spotting the eating disorders. And so she said this, how innocent we were when we thought working with eating disorders was a choice. And I thought that just crystallizes my whole theme here, that every dietitian is going to see people who have eating problems because that's what we do. And because only 1 out of 10 approximately eating disorder patients is actually diagnosed with an eating disorder, identified as having an eating disorder. And in specialty eating disorder care, that means 9 out of 10 individuals who are experiencing an eating disorder are in a diabetes clinic, are in an oncology clinic. And that's who I wrote the book for.
Beautiful. And something that brings up for me is, if you are listening, to please write down the population you work with, because I want to know, like, have you experienced working with someone who may have dysfunctional eating behaviors or a diagnosed eating disorder in a population that society may not think typically experiences these concerns? So please write that into the chat, because that is a very important point. Now, you often say that anyone can have dysfunctional eating behaviors, and you use that term a lot in your resource. So can you share what the difference is?
Yes. Okay. So I have I don't know what the right word is. And maybe this is from working with kids when I first started out, but I have a thing for saying what you mean and realizing that other people hear it in a different way. And so when I was working with kids, I really learned to be specific through a lot of different experiences. But just one example, a teenager turned 18, told me that now that she was 18, she wasn't going to follow her meal plan. She wasn't going to do anything recovery oriented. She was going to go back to having her eating disorder. And I kind of conceded that that was her choice. Well, her mom called me later that day and said, my daughter said that you told her she's fat and that she should go on a diet. And thank goodness this mother knew me. She said, I told my daughter Jessica would bite off her tongue before she would say anything like that. So I'm calling Jessica to find out what exactly happened. Well, I thought back. I was like, what could I have said? What could I have said that she could have interpreted that? You know what I said when she told me she was 18 and she was going to not recover? I said, you're a big girl. It's your decision to make. Well, so I learned from that. Say what you mean. Say what you mean. Use very specific words. And when we use, and also think about how the other person is interpreting your words. So when we say eating disorders, people, not everyone, I can't say everyone because I haven't been in everyone's mind, but the general public is thinking of very specific visuals, right? The certain kind of person who has an eating disorder, the size of a person who has an eating disorder, the type of eating problem that they have. And if it was just a misconception, that would be one thing. But the fact that the medical profession seems to think that, the fact that people are not getting help because they don't fit that stereotype, to me, that is a reason to not use the words eating disorders. So instead to say problem eating, dysfunctional eating is the choice I pick for sort of a clinical setting, but problem eating behaviors is same because to me, or disruptive eating behaviors, the goal is to say that anyone who eats can have an eating problem, and anyone who has an eating problem deserves to get help, even if it doesn't rise to the level of an eating disorder. So eating disorder is a very specific diagnosis to me. I prefer dysfunctional eating behaviors or problem eating behaviors because that encompasses everything. And when it comes to disordered eating, that I think is just a word salad. And I don't object to anyone using it if it makes sense to you and your population gets what you're saying. But for me, disordered eating is a confusing term because it sounds like you just took the words in eating disorders and flip them. You know what I mean? It doesn't have a sort of concise definition the way that problem eating behaviors, everyone gets that.
I love that. I love that you've shared different ways to express how challenges in eating can look like and what terms professionals can use. Now, just looking at the comments in our chat, I'm seeing a lot of people in the gastrointestinal space. So we do notice that anyone who may have, maybe they're not eating enough, they may experience GI issues, right? That can lead to dysfunctional eating behaviors. There are people that are working in a variety of different facilities, such as pediatric facilities, mental illness facilities. Now we're also seeing even in the geriatric population too. So these things can come up in a variety of populations, and I want to make sure that that's the message people are taking.
And it's a chicken and an egg situation sometimes, because it's easy to look at, and this is also sort of passe thinking in the eating disorder field, because remember, the eating disorder field was really started by PhD psychologists. So I'm not trying to offend anyone. I probably will, but I'm not trying to. But not someone with a focus on general medical knowledge, let's say, but very much like a think your way out of these problems kind of mold. And so it was easy to say, well, your stomach cramps are because you haven't eaten enough. When you eat better, you will feel better.
Mm-hmm.
And what we know now to be true is a lot of times the stomach issues predated the eating disorder, and someone has been trying to modify their eating in order to feel better. And so we can't count on just eating better will solve your GI problem. So I think it's really common for people to end up in a GI clinic versus an eating disorder program, and probably neither one is getting the full picture unless they have a dietitian in an eating disorder program who's familiar with GI issues, or in a GI clinic that's familiar with dysfunctional eating issues.
Which is why coordination of care is also really important too, which when we go through the book, we will get to that as well. Now, one of the questions on the chat is, how is this version of the book updated from previous versions? I think that's an important question. What are your thoughts?
Yeah, great question. So this third edition is, in my opinion, the most inclusive eating disorder book ever written, because it sort of occurred to me, and I've always been a person who thinks of eating disorders as affecting anyone who eats. That doesn't necessarily mean that was reflected in our words. So whereas the second edition said he or she, which at that time when it came out was like, what, he or she? Everyone just imagines she when they're picturing someone with an eating disorder. Now it has they. And so we're, understanding that certain populations actually may have more eating disorders, individuals who are non-binary or transgender. And it also has, in the case studies, it has names that represent different backgrounds, different ethnicities. In addition to sort of the demographic inclusions, I also made sure to include things. There are groups that are just historically excluded from eating disorder care and research. Well, they're excluded from eating disorder care because they're excluded from eating disorder research, because most eating disorder research happened on a college campus in the 1980s. And so you're just dealing with a very homogeneous population. And so we're talking about individuals who've been incarcerated, individuals with lower socioeconomic status, which is a fancy way of saying food insecurity, basically. Individuals who are disabled, individuals who are neurodivergent. These are groups that have specifically been excluded from research because they were considered outliers. And that's not fair, and it's not appropriate. And so in this book, I made it a point to specifically bring in issues. Oh, fat people. That's a whole other can of worms, right? So I made sure, or I tried to really emphasize in this book the nature of anyone can have an eating disorder. And we really have to stop using things like BMI or what someone looks like in order to make any kind of decision about their eating. It's also been updated with new aspects of the nutrition care process, new medications that have been, psychoactive medications that have been added since the last version. There's probably other things, but those are the things that come to mind. Oh, there is one other thing that's different from the third edition to the second edition, and that is an error. This is one of my secrets. I was told to come up with 3 secrets about the book. And one of the secrets, which shouldn't be a secret, is that if you look in the guide to dietary restrictions at the back, it's Appendix B, and it lists all the different kinds of dietary restrictions and what their qualifications are. So right now we happen to be in Lent. There's also kashrus, halal. There's also Seventh-day Adventist. There's all the different kinds of vegetarian and vegan. Yeah, it's gluten-free. It lists all the different kinds of restrictions and what falls in and out. And one of them is under medical diets, and it is low FODMAP. And the included and the excluded are reversed. Anyone who knows anything about FODMAPs would have caught it, but I didn't catch it. So I'm just letting you know.
Okay. So
secret number one revealed.
Okay.
Page 177. Yeah.
Okay. That's a good one. I didn't catch that one, so thank you.
I'm pretty sure no one is reading the Eating Disorder Pocket Guide to find guidance on FODMAPs, but it is in there because it is a restrictive diet that sometimes people follow, not realizing it's supposed to just be an elimination diet. So now you know, secret number one.
So something that I really love from this resource was the section on Am I Ready? I want to read a little spot because it goes into our next question. And it says, as a specialty practice area, working with individuals experiencing eating disorders can be intense and draining, and to be most effective requires additional training beyond what is provided in school and internship programs. Now, someone asked when a non-EDRD should refer to the specialist. And so the reason I'm bringing that up is because anyone could start using some of these tools and
anyone should.
Yes. And I want people to know that they can build their confidence. I feel like something that you've devoted your life to has been not only helping this population, but also helping professionals that work with this population, which this resource really helps. It almost feels like I'm just talking to you when I read this book. And it's like the ultimate Jessica pep talk in this pocket guide that helps you build the confidence that you need to take one step further to help this population. So what would you say?
First of all, you totally get me. Second of all, let me say that to the person who asked, when should a non-EDRD refer to a specialist? Let me say this. There are not enough eating disorder dietitians in the entire multiverse to care for all the individual people who are having eating dysfunctions. So we rely on non-eating disorder dietitians to help those individuals. So I'm going to say the reverse. Instead of when to refer, I'm going to say when to not refer. If you have, let's say you have a really strong relationship with a client because you've been their dietitian since they were 12, right? Because they have a metabolic disorder or they have diabetes or they have anything that has brought them into your care for a different condition, and you deduce that they have developed an eating disorder. Do not refer them to an eating disorder dietitian. Capitalize on that relationship that you already have, all the work you've already done, and get consultation with a specialist eating disorder dietitian for anything you're not sure of. Same with, well, I don't want to speak for other specialties, so I won't say same with blank, blank, blank specialty. I'll just say in the eating disorder field, a person is not their eating disorder. So once you've determined they have an eating disorder, they don't need to go to a different dietitian. Now, with that said, you can refer to a specialist anytime you want to, anytime you feel that you are, let's say, outmatched by someone's eating disorder, by someone's issues. Probably that would come along with someone who is either unable to actually eat PO. It might be someone who, with all the nutrition guidance in the world, is not able to eat adequately. But the truth is, even an experienced eating disorder dietitian can't cure someone's eating disorder. So they may not need a more experienced eating disorder dietitian. They may need a setting in which they can get more support around food. And so a more experienced eating disorder dietitian may sound like a good escape strategy because you're overwhelmed, but I would really encourage you to find a more experienced eating disorder dietitian and talk it through with them before you make a decision about whether to share the patient with someone else. You can even both see the patient, but you don't necessarily have to, let's call it sending the patient away. You might think about it more as let's bring a more experienced eating disorder dietitian onto this team to get some consultation.
Yeah, and supervision is so valuable. Not only does that help you with those harder cases, but it helps you build that confidence in working with the population too, which brings me to my next point. In this pocket guide, you guys have 2 different handouts or resources, if you would like to call them, that Jessica has on her website, understandingnutrition.com. And on her website, you can actually download the full color version of these handouts. So one of them is right there. This is one of my favorites, but I have a few other ones. But here is one of those resources. It is on page 137. You can go to her website, and then we have another one. Yep.
Oh yeah, there's the colorful version.
Screen. Perfect. Yeah. So that's just like an example of a resource that is in here, but resources that she uses in her work, but also in supervision too. It helps guide the dietitian, and they're all tools that can be used that are available for free on her website. And again, in this pocket guide. Another question we had, I want to make sure we get to these questions, but also I want to highlight that we have someone from Nigeria on this call and someone from Lebanon. That's pretty cool. International. Amazing. Love that. Okay, so one of the questions is, what do you believe private practice dietitians underestimate about building a sustainable eating disorder practice? What are your thoughts?
Oh, what do they underestimate? That's a very specific kind of question. I think that dietitians underestimate how many people need help, underestimate how much you need to keep your boundaries about which type of patients are the best fit for you. And I think overestimate how many referral sources you need. You don't need every doctor in America to refer to you. If you have, a couple of really on it doctors and therapists, they can probably keep your practice busy with individuals with eating issues, as long as they know what to look for. Wonderful. And in fact, I will say, I think an eating disorder practice is probably one of the most sustainable specialties in today's climate, because a general dietitian who says that they specialize in 92 different things, no one wants to see that person. Mm-hmm. People want to see the person that specifically meets their needs. So I think there is a huge need for eating disorder dietitians.
Now, in someone's private practice, when it comes to the coordination of care, which in your resource here, we have a whole section on different practitioners and how you can coordinate with them. One of my favorites, this was also brought up at a previous conference, was the occupational therapist when working with ARFID patients, because sometimes we don't know exactly where the origin of a feeding issue may come up. And by working and coordinating with someone who has specialized feeding tools. Here, let me just pause this for this comment that I was about to make, but here is another resource from your website, The Origins of Dysfunctional Eating Behavior Model, which is also found in the resource. But I love that tool. It highlights.
Thanks for mentioning that, Yasi.
Yeah, so the coordination of care. So let's talk a little bit about that. In a private practice setting, I think having a therapist, at least some sort of a connection with a therapist, local therapist that works with eating disorders, or just people who have different relationships with food, cardiologists, endocrinologists. So why don't we touch a little bit on how coordination of care can help, and when someone is in a private practice setting, how they can.
Sure. Well, one thing I can tell you is whoever is listening may or may not know that I started an organization called the International Federation of Eating Disorder Dietitians. And one of the things that we work on is insurance coverage for eating disorders. And one of the things that we're looking at is how to get dietitians paid for all that coordination of care that we do, because I think that we are the ones who put the most effort into making sure everyone on the team is up to date. And I think part of it is because we work on so many different areas, right? Someone might be seeing a dermatologist for their acne and a gynecologist for their irregular periods, and it's the dietitian who says, wait a minute, these two things are major hallmark symptoms of PCOS. This person needs to see an endocrinologist. So we're sort of the center of the wheel when it comes to referring to other providers. So yeah, I think it's really important to know who's who in your area and cross-refer. I used to have a course called Double Your Referrals Without Getting Off the Couch. And the main message was, look at the patients that you love to work with, see how they came to find you, and go back to that source and say, I love working with your patients. I have openings. If you'd like to work together more, let's do it.
Wonderful. And we have like 5 minutes, so I'm going to get to a few more questions,
Okay,
and then we'll get to those last tips.
Okay.
Now, for patients put on a strict diet restriction while inpatient in the hospital, how can we help prevent this from creating an eating disorder?
Yes. So first of all, we can't prevent all eating disorders, but what we can do is we can be very specific. If someone's put on a strict diet in the hospital, we can say, this is something you will need to follow for the rest of your life. Or we can say, this is something for the next few weeks. We're going to make you an appointment with an outpatient dietitian to help you transition off this diet at the appropriate time. We need to give an endpoint if there is an endpoint. We also need to be specific about words like avoid. I am a literal person, and maybe that's why I totally, was able to retrace my steps with that particular patient that misunderstood me, or I miscommunicated. Because when I would have a handout in the hospital that I'm supposed to give out to someone that says, avoid potassium. First of all, avoid it. Like, don't be in the same room with it. Like, I need specific. And so are we saying eat it once a week, eat it once a month, eat it? It's best if you can eat it not at all. If you have to, your better choice is beans versus bananas, right? We need to be very, very, very specific. And we need to check for comprehension. We need to ask the patient, what did you hear me say? Because I'm thinking of a patient who was put on a very low sodium diet because of her kidney failure. And once all the water fluid was drained off, she was emaciated because she had basically stopped eating because she was so afraid of having something with sodium in it, because she was a kid and she did not understand that, what the numbers meant, et cetera. So I just think we need to be very, very specific, because strict diet restrictions are sometimes medically necessary, but we need to specify exactly what we need or what we mean. And the other thing is, make sure that anyone who's going on a strict diet gets counseling, because the stress plus the food restrictions is what can cause an eating disorder. So helping someone manage their stress is actually eating disorder prevention, and having a medical diagnosis is an enormous, what could be more stressful than that?
And I think, dietitians have they play so many different roles in outpatient and inpatient settings. So when they are providing that education, if they have the opportunity to provide that education, just remembering like how that can impact the patient after the hospitalization or the next setting. Now, in this resource, you will find a ton of different tips on blood tests related to eating disorders, how to supplement if someone has a deficiency. There are a ton of great gems in here. Now, one of the last questions that I want to ask, and anything we don't get to today, we'll get back to it in some way. I trust that, Jessica, you care so much about anything that everyone's curious about. So we'll somehow get back to it. I know patients can refuse proving weight, which is in alignment of eating disorder practices, but how do you go about submitting claims that require BMI diagnosis? So I know that you did want to talk about insurance claims a little bit.
So there are no diagnoses that require a BMI. Okay, none, not a single one. If you look at actual diagnostic criteria, if you have OCD, you don't need a BMI diagnosis. If you have cancer, you don't need a BMI diagnosis. So anyone that's requiring a BMI for diagnosis is not following standard ICD-10 diagnoses. It's their own requirement or their own policy. And so you need to talk with that individual, whether it's an insurance company or whatever it is. I mean, what you can put in the note is deferred, unknown, varies. You can put all kinds of things. NA, you could put all those things in your chart note. But as far as what you do for the person, the payer, you have to have that conversation and say, my patients have a mental health issue or a medical issue, and BMI is not part of the requirement for that diagnosis, so it shouldn't be part of the requirement for them to get coverage. And I always quote, for some reason, I quote OCD. I don't know why, but I always say, when you are considering coverage for a patient with obsessive compulsive disorder, do you ask how much they weigh? It's a behavioral disorder. So if you're asking about a patient with an eating disorder, you don't need to know how much they weigh. I'll give you any other details that you want. They're throwing up blood. They've lost 40 pounds in the last month. But what their weight is today, is completely irrelevant.
Right. Right. There's so much more. There's so much more. And now that we're wrapping this conversation up, is there anything that you want the viewers to know? Any last minute tips or recommendations when it comes to the book? Now, before you share that, I also want to share that there are continuing professional education CEUs that folks can get from this pocket guide, and you get more than 7. So that's amazing. And it's
yes. So I guess what I'll share is that you're right. I will try to answer the questions that were asked, but I also would love to stay in touch. So if anyone wants to get in touch with me, you can DM me here on social media. You can join my email newsletter at jessicasetnick.com. If you just go there for a minute and hover, you'll get a pop-up, and you're talking about CEUs. I send out links to free CEUs in my newsletter every single time. I love to stay in touch. So I think that would be my one thing I would want to share.
And what about the IFED listserv?
Sure. So that's a great thing to mention. I mentioned before that I started an organization. It stands for International Federation of Eating Disorder Dietitians, and any nutrition professional, regardless if your credential isn't RD, that's okay. Any nutrition professional can join. It's ifedd.org. And we have a very active listserv that helps answer questions. People are very generous with their advice about specific patient cases, about referring to another professional in another state, or even another country. We have a lot of questions about how to refer a patient to another country or continent, and so many other things. But yes, I would highly recommend that. And there are so many resources. I would just say this book is great. It is not the only resource. It is definitely the one that is targeted toward people who are not specialists, but there is a list in the back of other resources. And I highly recommend anything by any of these other dietitians, because there's just a lot out there to help you if this is a population that you have a heart for. Everything else is just skills. And I'll say at the same time, if you just get frustrated, this may not be the field for you, and that's okay. But if you want to work in the eating disorder field, we need you.
Yes. Thanks so much, Jessica. And again, those additional resources, the list of Jessica's favorite resources are in here, but they're not limited to what's in here either. So there are a ton of online resources too. Stay in touch with Jessica, purchase the Pocket Guide. It has a ton of great resources in it, and tools to help you stay confident when working with this population, but really just expert insights from Jessica in this book. Thank you all so much for joining. We hope that you enjoyed, and we will get back to those questions, whatever we missed.
Thanks, Yasi.
Thank you.